Okay, I got it recording. Great.
How's everyone doing today? Oh, got a lot of mutes all of a sudden.
The only one I see that's dialed in is Mika.
What, you just ignore me? Oh, sorry.
Mika, and those of you that are on the phone, can you see my screen okay?
Yes, sir.
Awesome, awesome. And you can hear me okay?
Yes, sir.
Awesome. Well, based on those two things, I think we're already well ahead of where we were on Wednesday.
I agree. It happens, though.
I know. I know Charlie and I couldn't be more sorry for what happened on Wednesday. It definitely was not fair to everyone's time.
Oh, nope, no problem. No worries.
Okay, Adam, I think we can go ahead and get started.
Okay. Well, I'm going to leave this screen up for just a moment or two while I do a little bit of talking, just in case anyone happens to dial in or log in but is having trouble with the conference line. So for those of you that are on the phone, my name is Adam Kirking. I'm, along with Charlie, a Director of Operations for Imperium Health. I've been with Imperium for a little over a year, so Charlie's been with Imperium for probably about 8 months, and I've been just a little over a year. Pretty neat company. We're really excited about the chance to work with you guys today and talk a little bit more about annual wellness visits and transitional care management visits. So this is going to be one of our first webinar events that we're going to do. And our webinar series is meant to kind of build off kind of the key best practices and the key activities that we want to make sure that you're focusing on. And we thought that this was a good way to distribute some of the information because it allows for you to kind of absorb, what does this mean for you? And then be able to take some of it back and apply those best practices to your own organization. So today we're going to talk about implementing an annual wellness visit and transitional care management program. So going beyond just doing 1 or 2 visits, and what does it actually look like when we turn it into a program? We're going to then take it a little further and say, okay, of these actual visits, what are some of the components that we need to be drilling into to be really successful? And then there's going to be some things that we're going to discuss today that'll be almost like an introduction session. And then we're going to have a follow-up annual wellness visit and transitional care management visit excuse me, session a little bit later this spring. And during those second sessions, we're going to get a little bit more into some of the nuances and a little bit more into some of the tricks that we've learned along the way. And a lot of those things are going to be available within the annual wellness visit and transitional care management toolkits, which if they haven't been emailed to you already, those will be sent out a little bit later today. Okay. So to get started, and I'm sure many of you are already familiar with Imperium Health, but a number of the things that we really pride ourselves on are kind of shared learning, shared ideas, and things that we believe are best practices for our organization to do. And that building foundation That's going to be your annual wellness visit, your transitional care, your advanced care planning. Those are going to be some of the things that we're going to talk about today. And our webinar series that we're going to do over the course of the year is going to kind of build off a lot of these building blocks. So later this year, we're going to start to talk quite a bit more about the G Pro, and that's the same quality audit that you're going through right now. We're going to start to talk more about scorecards and reports and information that we'll have available to you as, excuse me, as an organization and as a provider level. And then I know one of the things that's already being done in many of your organizations or with your ACO is to start thinking about managing that post-acute care. So what happens when a patient leaves the hospital? And those are all kind of some of the building blocks and the steps that we're going to take along our ACO journey. But for today, we're going to focus on that. We want to make sure that we're getting the annual wellness visit and the transitional care management is kind of nailed down as much as possible. And as we go through today, if you have any questions, you can either put them in the chat box function that's down in the bottom right, or that's not part of your screen, or if you want to interrupt, feel free to do so. We want to make sure that you get as much out of this session as possible. So to get started, the two visits that we're going to talk about today are annual wellness visits and transitional care management visits. Both visits, I think, are awesome opportunities to increase your revenue within your practice. I would say the annual wellness visit is the perfect chance to identify and close some of your gaps in care. You're going to start thinking about who are my high-risk patients. And sometimes we'll use a term red patient to talk about these patients. So these are the ones that we almost need to stop, slow down, and think about all of the extra things that we need to make sure that we're doing for this patient in the moment to ensure that we're helping them to be as successful as possible. Doing the annual wellness visit is a great way to get more patients attributed to you, partially because it's a visit that pays pretty well, and partially because you're seeing a patient before they get sick. So if you're seeing a patient while they're still well, that's that patient that may go 2 years without seeing a doctor. We're bringing them in every year just to make sure that we're getting kind of all of our I's dotted and our T's crossed to ensure that that patient is being as healthy and as successful as possible. And then because we're bringing that patient in and starting to go over, okay, what do we need to do to keep you healthy, keep you well? We found it to be successful in increasing our patient engagement and our overall patient satisfaction. And now that's a well visit. So I'd like to think about that as almost like going to the dentist. You go to the dentist typically when you're sick. Now our transitional care management visit, that's going to be a follow-up after something happens to a patient where they go to the hospital. And it could be something where they go to the hospital and then they go to that post-acute facility like a long-term acute care, like an inpatient rehab. And then before the patient or when the patient goes home, we want to bring them into the clinic. We found looking at all of our Imperium Health discharges that a transitional care management is one of the best ways to reduce avoidable admissions. Again, it's one of the higher paying codes, so it's going to help to increase your attribution. It's the best opportunity to do that medication reconciliation post-hospitalization quality measure. And I know that's a mouthful, but essentially what that's saying is there's 15 quality measures that are like clinic quality measures that CMS evaluates us on. 14 of them are things that can be taken care of as part of the annual wellness visit. The medication reconciliation measure is one that's specifically tied to a discharge. So the transitional care management visit is the best opportunity to bring the patient into the clinic or even possibly do that med rec over the phone to ensure that it's taken care of. And then by really kind of training our patients to start thinking about the primary care providers are going to be the leader of care provided to our patients, it helps to increase that patient engagement. And I would say that's that kind of like stickiness effect, that we want to make sure that our patients are looking to us at all times as we are their go-to resource for care. So with that, we're going to jump right in and go into the annual wellness visit. And today we're going to talk about kind of an overview of the visit. We're going to go into a couple of the steps we want to make sure that you're focusing on. And then we're going to leave a little bit extra that we're not going to get into quite today. We're going to save some things because I don't want to overwhelm anyone. So today's discussion is going to be more about getting it up and getting it going. And then a little bit later this year, we're going to talk about some tweaking and some refining. So to get started, an annual wellness visit is not a physical. I think I always like to try and point that out right away. It's a once-a-year appointment that patient's coming into the practice, and you're kind of developing that personalized care plan. You're helping to support the patient to be kind of the most that they can be without being too army cliche about it. But you're going to make sure that you're doing a health risk assessment. You're going to make sure that you're reviewing those current medications, those current specialists. And the reason why I think that bullet or that part of it is so important is that too often within an ACO, we'll have conversations with the provider and they'll say, you know what, I'm not responsible for that referral. I'm not responsible for that procedure. I didn't make that. Well, within a Medicare Shared Savings ACO, the benefit to the providers is that they get extra information. You know, but it also comes with the caveat of you're also responsible for helping to best coordinate the care of those patients that are attributed to you. So knowing that bit of information from the patients and not having to wait for claims data can make such a difference in improving their care and hopefully helping to drive high value outcomes. Establishing that patient medical history, knowing what we should be starting to think about, starting to look for what those risk factors are, doing some of those screenings, that BMI screening, that, excuse me, that depression screening, to start thinking about, okay, what are some things that are going to be risky for our patients or things that could be more challenging for them later on in life that we want to catch when they're younger, want to catch when they're a little bit healthier. It's a chance to do that patient assessment. So you're doing that BMI, you're doing that blood pressure measurement, just to check to see, is everything going on with the patient? Is everything going on okay with the patient? I think that blood pressure measurement is so important because the more times a blood pressure measurement is done, the more times we can kind of have that, you know what, this is not a white coat syndrome thing. Your blood pressure has been high every time you come in here. And then develop that personalized prevention plan for the patient. And this is something that the patient will leave with, or at the very least has access to, that will outline, these are the steps that we need to make sure that we're doing to ensure that you're as successful as possible with your health, with your care for the next year. Things like ensuring that they're getting their mammogram done, getting their colonoscopy done, or maybe going for that walk once a day, once a week, or going to the mall once a day to go get a little bit of walk, maybe get some fresh air or some social interaction. So a slide that I put in here was some nuggets. So if you are pitching an annual wellness visit and you're maybe doing it to a provider, maybe you're doing it to a leader, and you only have a minute, these would be the 5 things that I would say if you're pitching it quickly, you want to get across. One of the first is that an annual wellness visit does not need to be done by the provider alone. I'd say that's a real failure if you're trying to have the provider do it all on their own. That turns into an hour-long visit, a 60-minute or 75-minute visit. That's not a good use of the provider's time because it takes away other potential visits that the patient could have seen or other potential patients that that provider could have seen. This is a team visit, and as long as you're not at a rural health clinic or a federally qualified health center, it's actually a visit that can be done by a nurse or another clinical team member if they're working under direct supervision of a physician. An annual wellness visit is not a true physical. Now, what I mean by that is the patient's not coming in and you're doing a panel of labs. You're not doing chest x-rays. You're not kind of doing that full gamut. Partially because sometimes those tests may not always help to provide the information that we're after. The annual wellness visit is really an information gathering visit. If a patient is after some of those extra services, there may be co-payments associated with those visits, associated with those services. An annual wellness visit on its own will not include the labs and the imaging that is sometimes associated with a true physical. An annual wellness visit is a chance to close or develop a care plan for 14 of the 15 quality measures, and that one that it doesn't is that medication reconciliation post-discharge. It's a chance to improve your attribution because it's a pretty highly reimbursed visit. And then you're going to start to document those underlying chronic conditions, those things that maybe we document once, but we don't remember to document every single year. And that's going to help you to be more successful within a Medicare Advantage program, as well as other kind of risk-based contracts, maybe like a Medicare Advantage, Medicare Shared Savings, but also like a Medicare Advantage program where they're going to put a little bit more emphasis around coding alone. So I bring this slide up because I think it's just so important to make sure that we're clarifying the difference maybe between an annual wellness visit and a traditional physical. A traditional physical is not paid for by Medicare, but an annual wellness visit is paid at 100% by Medicare and most Medicare Advantage plans. So what that means is that if it's a $170 visit, that's $170 paid for by Medicare, not $140 paid for by Medicare and $30 paid for by the patient. This is 100% paid for by Medicare visit. And again, that physical that you might be doing, If you're billing it on a Medicare patient, you're probably billing it as like a 99214, maybe even a 99215, and then some extra G codes on top of it. For a wellness visit, you're going to do it once every 366 days, or potentially a little bit sooner if you're starting to think about that welcome to Medicare visit, and that's the first 12 months that a patient is eligible for Medicare Part B. An annual wellness visit is going to involve that health risk assessment, review of kind of mental and cognitive deficiencies, evaluation of risk factors, and then you're going to start to talk about what are some of the other chronic conditions. That traditional physical, that's more of that hands-on exam. So there's a big difference, I think, between those two, and that the annual wellness visit, the kind of hands-on portions, those are more like the BMI and the blood pressure measurement, as opposed to taking the hammer and pounding on the knee and trying to evaluate every component of the patient's health. You can still do many of those things, but they're not necessarily required. And to be successful with an annual wellness visit program, so this is to take it from going beyond doing 1 or 2 visits and turning it into a sustainable program for yourself. I would say that there's these 5 things that you're going to really want to nail down for yourselves. And things that have a wrench in the bottom right-hand corner, those are going to be bits that we have available to you within the Imperium Health Toolkit that'll be sent out a little bit later. So the annual wellness visit is a pretty structured visit, so we want to make sure that your template is set up to be as effective as possible. I'm a really big fan of if you can capture something once, but maybe use it multiple times, that's awesome, because now we can benefit from making sure that it's documented to satisfy the visit, satisfy our gaps in care, and maybe even use information to satisfy a risk adjustment on a patient. We're going to want to make sure that our team members are educated, and that includes everyone from a registration team member to a provider, because having everyone understand the value of doing a wellness visit makes such a difference. And now when that patient comes in and says, that's it, you're not going to do labs, that nurse that's maybe helping to close the visit out with the patient when they're reviewing that personalized prevention plan can say, no, we did all of these other really great things to help ensure that you're going to be healthy for the next year, and they feel more comfortable with it. If you're going to verify that your billing and your coding are being done correctly, unfortunately, too many times I've had conversations with providers where they'll say, Adam, there's no way that I've done 50% of my visits. I know that I've done 100. And an annual wellness visit is one of those few visits that a provider knows how many they've done. So when we go in and we say that your billing isn't, or that your production isn't quite where we expected it to be, or that we were hoping for based on the goals that we had set, they get frustrated and they start to question the data. When unfortunately, more often than not, I've seen that it's actually a question of their billing maybe not being done correctly. And too often a biller doesn't understand what a G code is, or maybe what these specific annual wellness visit G codes are, and they bill it as a G0402, or sorry, or a 99214 rather than a G0402. I'd say to be successful with an annual wellness visit program, you're going to have to go beyond just scheduling those patients that you're maybe seeing every 3 months, 6 months as part of a follow-up, and you're going to have to start to be proactive. And this ties back to that increasing your attribution bullet that was on that one of those first slides. Being proactive about scheduling patients might mean a nurse calling a patient. It might mean when you have a patient in for a different visit, maybe the provider mentions, it looks like we haven't got your annual wellness visit done this year. Can we get you scheduled next week for one, or maybe even in 2 weeks, because this is a pretty important visit, but it's also a pretty thorough visit. So we want to make sure that we don't cheat your experience. And then I would say the leader, the providers, you're going to want to make sure that over time you're monitoring your performance to make sure that we're staying kind of on task, on kind of point with where we expected it to be. And I like to point out as part of that monitoring. So the monitoring performance, we're going to have goals that say, we want you to be at 80% by the end of the year, or seeing 80% of your patients. And part of the reason why we want you to see a few more patients as part of the annual wellness visit is because we believe that it's the right thing to do for the ACO. That being said, an annual wellness visit alone does not necessarily correlate to, an annual wellness visit is not a CMS measured visit or a CMS evaluated visit. It's a CMS reimbursed visit, but this is something that as an ACO, we're going to measure and try and do as well as we can on, because we think it's the right thing to do. CMS is going to evaluate us on those 15 quality measures. on our readmission rates, and they're going to evaluate us on what is our cost of care, how much value are we able to create. So within your EMR template, when you get that set up, and I'll be honest, every EMR is a little bit different, and I like to not be too prescriptive because every provider likes to document things a little bit differently. And what's important is that you're capturing information in a way that is great for you and allows it to be extracted as easy as possible. So within your EHR template, there's going to be some things that, and within the annual wellness visit, some things that are easy to document from a billing perspective, like you may be using G codes or CPT2 codes, and there's going to be some things that you can usually capture through the EMR if they're entered in the right place. So one of those might be the BMI screening and follow-up. So the follow-up portion can be really hard to pull as a report if you're not billing for that follow-up portion. The BMI is usually something that you can enter. It's usually entered into a discrete field, and you can pull that number out. A blood pressure measurement, the 135/80, you can usually pull that number out. That's usually something that can be extracted, or those chronic conditions, those can usually be extracted. But a review of a breast cancer screening or a review of a colorectal cancer screening, so that's to ensure that not only did the patient have the exam, but we verified that the exam was done. And we verified that we have the information about the exam. Those can be a little tougher to capture through EMR extraction alone, and sometimes you need to include those G codes for that as well. And those G codes, as part of that information capturing, that'll all be provided in that annual wellness visit toolkit for you. Assigning the roles and responsibilities, and I would say for this, it's making sure that everybody's in the right seat on the bus. It makes such a difference to be successful with the annual wellness visit program. And now on here, we have 6 distinct kind of bodies or 6 distinct responsibilities. I know that every practice is different. Every clinic is a little different. And every location within an organization is going to be a little different. So sometimes it doesn't make sense to think about these as 6 bodies as much as 6 sets of responsibilities or tasks that need to be completed at some point. The registration team member, usually that person that sits at the front desk, that when the patient comes in, they verify, I'm Adam Kirking, I'm born on June 3rd. They're the one that we're going to make sure that we're also having them hand out a health risk assessment. And usually we're having some sort of an assessment that's completed today as it is, but this is just to make sure that as part of that annual wellness visit that's being done. We're going to look to convert some follow-up visits to annual wellness visits if the patient's okay with it. And that's, Charlie, it looks like you're in for an annual wellness, or it looks like you're in for a 6-month follow-up. No, you haven't been seen for an annual wellness visit. An annual wellness visit is a little bit more thorough visit than a regular follow-up. The benefit of doing an annual wellness visit is there's no charge to you as a patient. Would you like to take part in that visit as well, or like to take part in that visit instead? Now, if you're doing both the traditional clinic visit as well as the annual wellness visit, as long as you are at a traditional fee-for-service clinic, you can bill for both of those visits at the same time using a 25 modifier. And that ties into the biller encoder to make sure that if we did do 2 visits, we're billing for it correctly. That if we did an annual wellness visit, that we're using the correct code, the correct G code to bill for that. That ensures that we're having that 12 code capacity when we're doing our billing, so that if we're trying to close those gaps in care, we're capturing as much information as possible. The clinical team member, you're really going to be our rock star within the annual wellness visit, because we're going to lean on you to be doing that blood pressure, the BMI measurement, and any other kind of routine measurements that you as a practice feel like we want to make sure that we capture this on every visit. And that could be temperature, that could be respiration, some of those things that you know that you believe are best practice for you, even though they're not necessarily required by CMS. You're going to review that health risk assessment for any gaps or maybe concerns that the patient has. You're likely completing the mini mental exam with the patient, and we have an example of that as part of our toolkit, but it involves, here's a clock, can you draw the time? We're going to say a couple words off to you, can you repeat them back to us? The scheduler is going to be the one that uses ATO Health Solutions to identify those patients that have not previously had a wellness visit and try and get them scheduled. And they're going to be proactively reaching out to those patients to see if they can get them into the clinic or into the practice for a wellness visit. And that scheduler component, that might be a task that's shared by multiple people, because sometimes a patient hears it differently from a nurse than they do from, I'm Adam Kirking, I'm your registration team member. I'm a registration team member at Dr. Bunnell practice. The provider, you're going to be responsible for overseeing the success of the entire program. And that's really one of the most important parts, just to make sure that you feel comfortable with the overall program. And then you're going to review that personalized prevention plan with the patient. Now, if you are not at a if you are not at a rural health clinic, or not at a federally qualified health center, so if you're just a traditional clinic that would be billing for 99213s, 214s, the provider can actually just serve as kind of the overseer of the program and provide direct supervision to other clinical team members. What I typically encourage is, I view the provider as part of an annual wellness visit, almost like you do a dentist as part of a dental exam, where when you go into the dentist, you're spending the majority of the time with the hygienist, maybe the registration team members. The dentist comes in at the very end, shines that bright light in your eyes, maybe pokes you a couple times and tries to have that awkward conversation with your full mouth, and then you move on. And then the administrator, they're going to make sure that the overall program is going as successful as possible, and that we're able to kind of work through any inefficiencies. And some of that might mean if a provider is taking more time than they are required to for doing the health risk assessment, that we figure out how can we schedule these visits a little bit differently. How can we ensure that we're able to not only meet the needs of our patients in front of us, but meet those other patients that want to be seen by our providers. So the next step to getting your annual wellness visit program going is ensuring that you're billing correctly. And I would say that if you're not using all three of these codes, you're kind of cheating yourself and cheating the program. And when I say cheating yourself and cheating the program, the IPPE, that G0402, and the initial annual wellness visit usually pays about $165 to $170. The subsequent annual wellness visit, that G0439, pays about $110 to $120. So if we're not using those first two codes, if we're skipping right to the initial annual wellness visit, we've kind of over the course of the cycle lost out on the opportunity to bill for that G0402, that a little bit more expensive code, which it sounds counterintuitive from an ACO perspective. Why would I be promoting you performing a visit that will pay a little bit better? I'm promoting it because it helps to improve our attribution, and I want to make sure that you're rewarded for the work that you're doing. You're going to do a IPPE, or that Welcome to Medicare visit, within the first 12 months of a patient being eligible and enrolled in Medicare Part B. You're going to do the initial annual wellness visit and the subsequent annual wellness visit 366 days later. I've seen practices that have said they billed it on the 12th month and been fine, meaning that maybe they saw a patient December 15th, and then the next year they saw him December 1st, and they billed it, it got paid, awesome. I've also seen practices that said they billed it on day 365 and been denied. So that December 12th, December 15th, turned around, they billed for it on December 15th again, it gets denied. My interpretation of the CMS regulations and Imperium's interpretation is 366 days. So that's a year plus a day. So if it's December 15th this year, it's going to be December 16th next year. And for all three of these visits, there's no co-payment for the patient, and they're 100% reimbursed by CMS. If you're an FQHC, bill G0468 for the three codes. And if you're an FQHC, these pay about 34% higher than a normal visit. So higher than your normal PPS rate. So there's value in doing those visits. Now we're going to jump into the transitional care management visit. And the transitional care management visit, again, is different than that wellness visit, where I like to think of the wellness as you're going into the dentist to have your teeth cleaned. TCM visit is more like you're going into the dentist to have your tooth pulled. And this is a visit that I believe makes such a difference in kind of sticking that relationship between the primary care provider and the patient, and helping to make sure that our patients are being as successful as possible when they're going home. And when I say successful as possible, what I mean is I want our patients to thrive when they go home. Because if you go home after being discharged from a hospital, and I've been discharged from the hospital before, and I'll be honest, I'm glad that I had others with me that were able to listen to the information, because it was overwhelming. And the TCM visit is the opportunity to start to have that okay, I have questions about these different things. I have questions about the medications I was supposed to be taking. And doing that TCM program is effective at reducing your readmissions. So the graph on the right looked at Imperium discharges from 2016 and 2017 and the impact that TCM visits had on them. A transitional care management visit can be done after an inpatient stay, a long-term acute care stay, so that's maybe like a health cell, an inpatient rehab stay, a skilled nursing unit stay, and an observation stay. And an observation stay is typically you go into the hospital, maybe you start in the ER, and they put you in a bed, but you're not there for a couple days. If you're only there for 1 or 2 days, it's usually considered an observation stay because you need to be there for 2 midnights to satisfy inpatient stay rules for a hospital. So that's where an observation stay can be important. And then I like to also clarify that a skilled nursing unit is different than a nursing home. A skilled nursing unit is maybe you had a knee replaced, a hip replaced, and you go to the hospital, you're in the hospital for a couple of weeks, and then you go to this kind of really nice nursing home type setting for a couple of weeks, maybe a couple months. And within that setting, you're getting a lot of extra therapy. They're doing extra things for you to try and get you back up to as close to normal as possible. And then you're usually discharged home. So that, in my mind, that's different than, in CMS's mind, that's different than the nursing home, which is it's a Medicare or Medicaid program or a self-pay program, and you're usually in a nursing home for a couple years. Maybe it's usually 6 months to kind of the rest of your life that you're in a nursing home. A nursing home is more comparable to like an assisted living facility. So similar to when we talked about those annual wellness visits, we said there's 5 things that we really need you to do. To be successful with the TCM program, I would also say that there's 5 things that I really need you to do or we really need to get kind of figured out. And we're going to talk about a couple of these today, and a couple of them we're going to probably follow up with a little bit later this year, a little bit later this spring. And the first is we need to make sure that we're getting our discharge notifications. Now we have a form in our transitional care management toolkit that we believe will help you to be successful with that. And just maybe something you can send to a local hospital to say, these are our providers. If any patient self-identifies as one of these providers, please send us a fax of their information. And I would say doing that self-assessment of where our patient's being discharged from can make such a difference. Once you have that discharge, now the next step is we're going to need to do a interactive contact between the patient or the patient's family and a clinical team member within the clinic. And that means not necessarily a physician. This is probably a nurse, probably a CMA. This is a clinical team member that's going to be reaching out to the patient within 2 business days. And I need to clarify that. It's 2 business days to ensure that the patient is kind of thriving and have what they need. Then you're going to bring the patient back into the clinic in 7 or 14 days, depending on kind of the medical complexity or your own schedule, to do a face-to-face visit. You're going to need to make sure that you're billing for these correctly every time. Similar to that annual wellness visit where sometimes a biller or a coder doesn't understand what this is. Too often I've seen a TCM visit at a very successful program or very successful practice, even very successful dedicated TCM team members, their biller billed it as a 99215 because they didn't understand the code. For example, a 99215 would probably pay about $110, and a TCM visit will pay about $230. So this TCM visit is one of the highest reimbursed codes I've seen for any clinic visit. And then over time, you're going to need to be making sure that you're monitoring performance and making those adjustments, those tweaks, maybe reaching out to extra facilities as necessary to ensure that you're being successful. So the first thing, and I would say really kind of the linchpin for being successful with the TCM program, is the discharge notifications. Because if we don't know that the patient was discharged, it's pretty darn hard to track our TCM progress overall. And I would say that sometimes we're going to track what we're able to get, and if we're able to get discharge notifications from a hospital but not the post-acute facilities, let's try and track where those patients are going and maybe keep a pulse on them. And these are set up to be kind of most complex to least complex in terms of how we're able to get access to it. The least complex is having a patient contact us directly. That means that if a patient was discharged from a hospital, maybe on their way home, they call us and say, Dr. Smith, this is Adam Kirking. I was just discharged from a hospital. The caution I like to give people about making sure that the patients are having us or contacting us directly is start to make sure we're asking good questions, because if a patient says I was discharged from a hospital in New Orleans, there's more than a couple. So we need to make sure that we're knowing which hospital the patient was discharged from, because that'll make it easier for us to get those discharge notifications or that discharge information from the hospital. I've seen some hospitals that give clinics access to their EMR, and the clinic just knows which patients are there. So maybe every day or every couple of days they go in just to check and see which patients were discharged from the hospital. And if one of those was one of their patients, then they call the patient to try and set up that interactive contact. Set up that TCM visit by doing the interactive contact. One of my favorites, if we can get there, is having the hospital or the post-acute facility. And again, that post-acute facility, that's your nursing home, your skilled nursing unit, your long-term acute care facility, your inpatient rehab, that they're going to send usually send a fax to the clinic directly. Sometimes they'll even do a call, but usually the most effective is if they can send a fax. And the fourth way is sometimes you'll have a health exchange or some sort of other like external discharge portal that'll be set up that will usually feed like admission, discharge, transfer notifications through a central, almost like a central clearinghouse, and communicate that information out to practices. So the interactive contact, and I said that once you find out about the discharge notification, now it's all really pretty manageable. And an interactive contact is you need to do at least 2 attempts. If you reach the patient on the first attempt, then you're good. But you need to do at least 2 attempts within 2 business days. So 2 business days is today's Friday. So if a patient is discharged today, we would have Monday or Tuesday, because we wouldn't count the weekend. Or the same as if a patient was discharged tomorrow, we would have Monday and Tuesday. If a patient's discharged on Monday, we'd have Tuesday and Wednesday. If a patient's discharged on a Thursday, we'd have Friday and Monday. It would be those 2 business days. If you have a holiday that's in there because the 4th of July, Memorial Day, that allows for an extra day. And then the interactive contact needs to be done by a clinical team member. So this is not an administrative call by a registration team member or scheduler. There needs to be a clinical team member on at least part of the call. Could mean that you have a scheduler contact the patient, and then they transfer the call to a CMA, maybe to a social worker, to a nurse that helps to kind of go over some of those other questions with the patients about, do you have any questions about your discharge information? Do you have any questions about your medications? And you could even do the medication reconciliation right there on the phone. Were you able to get all of your services kind of reinstated? Things like maybe the patient was receiving home health or therapy. Were they able to get those things back up and going again? And then the call must be documented somewhere. If it's documented in a notebook, that's fine. Let's just make sure that we have the notebook available to us. I would say make sure that you're scanning that in so that when the provider is doing the 7-day or 14-day face-to-face visit, that we're having that information available so that they know what questions maybe the patient happened to have. If you're able to document as part of a EMR, like a phone interactive contact or a phone interaction, that's kind of my gold standard. Is if you can do it that way, that's best, because it's usually easiest to pull forward that information into the face-to-face visit. Similar to the annual wellness visit, having everybody sort of having the right seat on the bus makes such a difference for being successful with a transitional care management program. Your clinical team members, you're going to be doing that interactive contact. You might be working with the patient or the hospital to get those 7 or 14-day, to get that discharge notification information sent to you ahead of time. You're going to be working to probably get that visit scheduled, and you're going to be supporting the medication reconciliation. For the provider, you're going to be really overseeing the whole program to make sure that you feel comfortable with it. And then you're going to do the medication reconciliation. You're going to do a face-to-face visit, and that's going to be similar to any other post-hospitalization follow-up that you were maybe doing before. You're going to reinstate any of those pre-admission treatment services, and then speak with the patient and the patient's family about any questions that they might be having. Your biller and coder, I would say the most important thing is just make sure that you're billing it correctly. A TCM visit can be billed the day of the visit or the day after the visit. the TCM visit no longer needs to wait until day 30 to bill it. A TCM visit can also only be billed by one provider per discharge. So if two providers, maybe a primary care provider and a specialist, both perform a TCM visit, patient's discharged on a Friday. One does the visit on a Thursday, the next one does the visit on the Friday, the following Friday. Only the one that billed for it first, regardless of who saw the patient first, whoever bills for it first will be the one that gets paid for it. The administrator and the manager, we may need you to reach out to some of your local hospitals or local post-acute facilities to make sure that we're getting those discharge notifications. We're going to need you to monitor the overall success of the program just to make sure that things are going the way we expected them to go. And we're going to need you to make sure that their workflows make sense and that the workflows are a good use of everyone's time. When I say that, I mean you're allowing people to work to the top of their capacity. If you're having a physician make a phone call that could be done by a clinical team member or a non-clinical team member, that may not be the best use of that physician's time. So let's make sure that we're able to kind of maximize everyone's capacity by letting them work to their top of their clinical credential or top of their kind of capability. So to go into that billing, now this is going to be a little confusing, so I'll do my best to try and slow down and take my time. But there's two codes that you can bill for doing a TCM visit, and you're only going to bill for one of these two codes. Typically, we think about the 99496 as a 7-day visit. So yes, it is a 7-day visit, but it also must have high complexity decision-making associated with it. And we're going to have some extra information available within that toolkit about what is high complexity decision-making and kind of what does that really mean. But essentially, it's like saying that you're going to document things similar to how you would maybe a 99215, or if you're a provider that rounds in the hospital, you're going to document it similar to how you would a 99233. Now, I know a lot of you probably are not familiar with a 99233, so I would not stress about that in any way. But it's comparable to how you would document a 99215 for doing that 7-day 99496. So if you're having a patient that you're seeing on day 5, but your visit note, maybe the interaction is more comparable to how you would document a 99214, you actually probably should really bill it as a 99495, which is the visit that we typically think about as that 14-day visit. So a 99495 is going to be associated with more of a moderate level complexity decision-making or moderate clinical complexity. And then you're also doing that 2 business day face-to-face contact, and it's going to be comparable to a 99214. I would say between the two visits, I always promote try and see the patient within the first week if you can, because there's going to be some patients that you might think are not going to need quite as much attention. You bring them in and you go, oh boy, you are not thriving at home the way we expected you to. We really need to make sure that we're doing everything we can for you. And sometimes with a TCM visit, it makes sense to see the patient 2 weeks later. So if you bring the patient in and you see them on day 5 and they're not doing the best, maybe bring them back in on day 20. Maybe bring them in the next week. And if you bring them in for a separate visit, that's a separately billable visit. So there's going to be some things as part of a TCM visit, and this will be in the toolkit as well, that are going to be considered like part of a clinic bundle almost. So you're not allowed to bill for care plan oversight at the same time that you're billing for a 99496, because it's like saying that the work associated with that $230 99496 is greater or essentially encompasses the work associated with that care plan oversight visit. To support you in being successful with this, we're going to have those Imperium Health toolkits that'll be sent out to you if they haven't already. We'll be providing any re-education that you'd like for ACO Health Solutions to make sure that you're able to get the most out of it you possibly can. And then Charlie, myself, and Cameron will be supporting you, as well as Wendy, supporting you in any way that they can to make sure that you're able to be successful with this. And then a couple things that I would like you to start thinking about for your own practice, how you could be successful with an annual wellness visit or TCM program, are, each of them has 4 questions associated with them, but do we have an EMR template in place for a wellness visit? Did we educate our providers about what the visit is? Did we verify that our billing and coding staff know what they're supposed to do, especially if we've been billing for these in the past? And then have we started proactively scheduling our wellness visits? And that means that if you're, say, have 300 patients that are attributed to you, or have 300 Medicare patients, maybe you want to be trying to do about 6 to 8 of these a week to make sure that over 50 weeks you're able to cover your whole panel. And then for the TCM program, you're going to want to make sure that you're getting discharge notifications. And if you're not getting discharge notifications, and we can use ACO Health Solutions as a way to start to identify, where are we having discharges from, and then we can kind of work our way back through and work our way back to say, you know what, we're not doing TCM visits for discharges from a given hospital. We're not doing discharge notifications from patients discharged from Ochsner, for example. And we're then able to educate Ochsner or educate some other hospital or skilled nursing unit on, we need to make sure that we're receiving these discharge notifications because we believe it'll help to lower the readmission rate for our patients. And we know that you're penalized if you have a high readmission rate. And then we're going to make sure that we're educating our team members. We're establishing workflows that make sense. And then we're going to have accurate billing and coding. So at this point, I'm going to open it up for questions, any questions that you may have.
Charles, this is Angie at Family Doctors Oakwood. I think we're way ahead because we do most of this already. Actually, all of it.
Awesome. So Angie, what would you like to know next, or what would be helpful for you to know?
I think the biggest part would be the annual wellness, because our nurse practitioners do a lot of those annual wellness, and I think that's what a lot of them, we have a template that we use for certain insurance carriers that one of our nurse practitioners built and that they use. So most of our annual wellnesses are done by our nurse practitioners. And, we do have a template, I know, for one, maybe 2 of the carriers that they use, which I'm sure they could use the same type template for this is regular Medicare, so for Medicare patients also. I don't know why we couldn't use it. But the TCM calls and those we do pretty much, the nurse practitioners make it. The scheduling desk schedules those for us. The nurse practitioners contact the patients, and then if the physician sees it, we bill for those visits after.
Outstanding. Okay. Any other questions from the group that you have at this point? The things that you're curious about? And again, if you have any questions, you can either say them verbally if you unmute yourself, or you can use the chat box that's on the part of the webinar to provide any questions. And Charlie, if any questions are going directly to you, feel free to answer them or to read them out loud. Okay. Well, on the screen right now, we do have Charlie's email, Cameron's email, my email if you have any questions. So Miss Lori asked, can you bill for the depression screening code? Oops. Somebody else asked a question. Can you bill for the depression screening code, or is that part of an AWV? I'm going to scroll back up to that, the billing. So the G0444 It's like a $10 or $11 depression screening code. You can bill for that as part of the subsequent annual wellness visit, but you cannot bill for the depression screening that's the one that you get paid for as part of the G0402 or the G0438. It is something that is essentially included like a mini bundle for these two, but for the 439, you can bill it separately. Wendy asked, many practices have a large attribution of nursing home patients. How can we improve annual wellness visits and TCMs dealing with nursing homes? For the nursing home patients, you can do an annual wellness visit in the nursing home. So if you have a nurse practitioner or PA that maybe rounds in the nursing home, if they fill out a template or bring a template with them, they can do an annual wellness visit in the nursing home. And we found that to be successful in Kentucky for some of our practices that have high nursing home populations. And that's a way to gather a lot of the information or close those gaps in care to ensure that when it gets to be G-Pro time, we're able to be successful with it. And Charlie, you can correct me on this one, but it was my understanding that you're not supposed to do a TCM visit if a patient is discharged to a nursing home. Is that correct?
That's my understanding, Adam.
So Wendy, for those patients, I would say we should still do a follow-up, and I would say we should still make sure that we're doing that post-discharge medication reconciliation. So even though it's not a full TCM, I would want to make sure that we're getting our med rec done and trying to see the patient that within that 7 or 14 days, just to make sure that they're able to be successful. From a personal experience, I had a grandma that was discharged from a hospital, went to a nursing home, and it seemed like just about every week she went back and forth between the nursing home and the hospital for a pretty extended period of time. So doing that face-to-face visit can make such a difference as soon as possible. Okay. If there's no other questions, we can let everyone else go unless Charlie has any other announcements or things that he wanted to share with the group.
No, I'll get the toolkits and the recording out this afternoon.
Well, thank you everyone for your time. I hope everyone has a great weekend, and talk to you a little later.
Thanks, Adam.
Bye, everyone.